Okay, so what I'm going to do first of all is just to sort of frame the day really with where we are regionally and nationally with MEaCC. As Mike said, this work has been going on now for about 10 years, I would say, in earnest. I'm just going to take you through how we've got to where we are, partly because it's great to kind of look back on that from my perspective selfishly, but also because it kind of helps you to understand how we've got where we are and potentially helps to kind of encourage other people or to see the ways in which they might be able to implement similar things in their own regions or nationally. So we're going to talk a bit about what enhanced maternal care is. It is something that is increasingly coming into kind of day-to-day parlance, but you still hear a lot of people talking about HDU care. So we'll talk about the difference between the two and why it's important to call it enhanced maternal care. Bit of a description about the MEaCC project and where we are nationally at the moment. So why is it important? You'll have all seen these slides and I've updated it recently with the slides from the Embrace report that came out in October. Looking at it at the back, I can't see all the detail here, but I am a little blind but also vain, so it might be that. But you can see that when Embrace looks at the maternal death cases, there's a significant proportion where care could have been done better. There's a very small, the smallest wedges on there are good care and women died in spite of good care. Encouragingly, things seem to be improving, but they're still not back to where they were pre-pandemic, and I think we had already a lot of improvement to do in that pre-pandemic era, so lots of work to continue with. Why is it so difficult? Number of different reasons. So the first is there's no one place that can do everything. And if that did exist, it would be great. It would still be difficult because of all the different people that needed to be involved as well. So on Delivery Suite, we've got an ideal environment for a woman who is pregnant and delivering their baby, and obviously proximity of a neonatal team, which are going to be there to support the baby as well. Critical care units are often on a different site as they are in our hospital and require hospital transfer to get there, which, whilst critical care might be good at doing things like invasive monitoring and inotropes and kidney replacement, all those kind of things, they're not necessarily well trained in how to look after the maternity-specific aspects of care. And you've also got that issue of proximity. There's more senior critical care nurses that I've worked with, most of them have a story of a baby accidentally popping out at some point while they've been looking after a sick woman in critical care. And my concern around that is that those senior staff had all got some midwifery training in their background, and that's much less common now. So, and similarly, training in intensive care is separating off, so you wouldn't necessarily have the intensive care medical staff doing anything on labour ward apart from in as a medical student. That is coming increasingly. And you've also got that issue of proximity that I've already mentioned, and what is your plan if a lady needs a perimortem section or an urgent section and the maternity theatre and the neonatal team are a significant distance away. Medical wards really came into play a lot during COVID with women admitted onto respiratory units, and they probably have even less experience of looking after really sick women who are just going to deliver in front of them. And there are a lot of units that did experience women delivering emergently in medical ward areas. So they're not to be forgotten. And there's more areas, obviously, in A&E is one of them, where we really need to make sure that we're providing the right care for women and babies. So what is enhanced care? So the document that you can see top right was the first to really define enhanced care in any setting. So maternity was ahead of the game with this. It's come into more general parlance since the pandemic because there was a recognition that critical cares just weren't big enough for all the patients that needed some additional care. So certainly outside of maternity, it is spoken about more often. And that's reflected in the updated levels of care that the Intensive Care Society has published in the last couple of years. So essentially it is care. So the point it starts at is when you're worried that a woman might deteriorate. And in terms of what that looks like, it's a woman who is needing observations more than 4 hourly for reasons other than having a baby. So that's quite a few women. And in terms of what we currently capture within the enhanced care data and what people consider enhanced care, I think that is a low threshold, but it was deliberately done so that we didn't miss people. In terms of where it flips from enhanced care into critical care, level 2 care or HDU care, which is why we shouldn't be calling it HDU care, that's up to the individual unit to decide. There was a long period of time where there was discussion around provision of invasive monitoring on delivery suites, and that will work in some units. We do it in Bradford. We've got about 6,000 deliveries a year, and unfortunately a lot of women with complex health needs, and that means our midwives are exposed to sufficient arterial lines for them to be able to maintain competence. That isn't the case in smaller units. That's okay. You can't have one size fits all for everyone. But what we do need is to say, okay, we recognise that this is now outside of our skill set in our maternity unit, and we're going to transfer the woman to critical care and put in what we need in critical care to support the maternity side of things. The other option is to have critical care nurses working alongside midwives to provide the care, and there are some units in the country that do that. However, it is expensive, and in this era of austerity and funding issues within maternity, I think it'd be pretty difficult to get that off the ground from scratch now. We just need to make sure that we choose a model in each individual unit and we stick to it. So it's not dependent on who happens to be on shift. When you hit that point that you have defined that woman needs to go to critical care, they go to critical care. And in that way, your staff will feel like they've got the skills that they need to support the women in the area that they're in, and the women will get the best care. So these are some of the things that enhanced care might include, but again, you just decide what you want in your unit. And so it's this enhanced knowledge of maternal critical illness, and providing the staff that are caring for the women with that knowledge, and starting to recognise where that escalation point to critical care is, so that they can be helping to guide the team on the shop floor to make that decision at the right time. And then it's enhanced skills. These are some of those things that might be included. There could be others. But just again to reiterate, it doesn't have to be about invasive monitoring. If that doesn't work in your unit, don't do it. Just have a plan to move the patient to critical care. So, the MEaCC project, dear to my heart. It's a long time in the making, so I think we're about 10 years in now in this region. Essentially, what it aimed to do was to improve the care of sick women, and that by association, their babies. And it encompasses training, so standard and enhanced competency training, and more about that later. But just to say now that standard training is probably, I think, the most important bit, because that is what allows your staff to recognise that there is a woman who is sick, and actually that's probably the most important bit of this pathway. And then there's also sharing of experience and learning, those models of care that I've described, and also just a kind of group really that supports each other when we run into difficulties, and everyone will have had the similar issues at different times. So we have ongoing steering group meetings quarterly where we meet, we update, and we continue to improve together. And then thirdly, data collection. A lot more on that later, but actually, how do we know we're doing a good job? This database didn't exist before we started enhanced care, so nobody knew the size of the issue in terms of how many women were getting sick, and we didn't know the outcomes for the mum or their babies, and we didn't know whether critical care or delivery suite was the right place to deliver. So more on that later. So I'm just going to take you through a little potted history of MEaCC. So as I've already said, it's been going since 2014. It wasn't me that started, but I did get myself nosied into it quite quickly, because I'd heard that the network was interested in what we were doing in terms of looking after sick women. And I don't know if Sarah Winfield's here yet, but she'll definitely remember me barraging into a meeting in Bradford and saying, what's all this about? And definitely want to get involved. After that, she completed those trust engagement visits and held a stakeholder event, which lots of people in the room will have been at. All 13 trusts from Yorkshire and Humber, and I think that's 17 units, attended that. And following on from that, we did a further benchmarking and established the task and finish group to set up MEaCC. Now, that task and finish group initially was just to translate that 2018 document. You'll notice the issue with the dates. So we had it in its draft format before, because Audrey Quinn, who was the lead author on that, had given it to us in advance. But it was to introduce that competency framework and this way of working across the patch, but in a way that suited all of the trusts that were within the patch. Just having a small IT issue. Would you be able to just advance the slide? Thanks. So, what was important about that benchmarking was that it involved all trusts. We weren't telling anyone what to do. We were just saying, what do you need? All trusts said that they felt that they were providing a safe service, they had good MDT relationships, but they did recognise that there was room for improvement. And that was from people on the shop floor. It was also from risk and governance people who had various incidents that had highlighted women becoming unwell and deterioration. They wanted the regional support and standardisation of training competencies. There was concern about the issue around the arterial lines. So recognising that early really helped us to kind of do something that worked for everybody. And they wanted those flexible recommendations that was tailored to the needs of the service. So Steering Group established in July 2018 with quarterly meetings. It's an MDT meeting. It's online now. It used to be in person. But being online, it means that essentially anyone who wants to come is welcome from any of the trusts. And actually, there's a few people, for example, Anita Banerjee regularly drops in to say hi at our meetings from St Thomas's in London, which is really great because it's kind of fostering those different relationships with people outside of the patch as well. And what we're aiming to do is to reduce unwanted variation. Variation is okay, but only where we've actually decided that it's the right variation. That we're providing access to training with support around which training packages and supporting each other with staff attending training in different units. To improve the knowledge and skill of the workforce across Yorkshire and Humber, and then in the long term to improve outcomes for our women, their babies and their families. So these are the recommendations and the training competency framework. For those of you who have seen those recommendations, they will now look quite familiar to the national document I'll come on to in a bit. So if you have implemented those recommendations, then you are already ahead of the curve in terms of what's happening nationally in this space. And then the competency and training framework is there as well. That is unique to this region. It wasn't part of that 2018 document in its entirety, although there are some similarities there. It's just got more detail in it and it's less focused on the invasive monitoring. So data collection. We recognised early on that we needed to know whether what we were doing was worth it, essentially. And after looking about, we realised that we had some data within MSDS, but it wasn't sufficient to track what we were doing in this space, and we needed more data. We also recognised there was a disconnect between maternity data and critical care data, and that because everyone had different points of transferring to critical care, you couldn't look at critical care data and make any judgments about the quality of the care provided or the point of transfer, because it needed by definition to be different. So you needed the whole database, so the care provided in delivery suite as well as that on critical care. And again, we got buy-in from everybody. The database works on an online platform. You'll hear more about that later. We got agreement from Caldecott Guardians. We have data sharing agreements in place. So we're meeting all of the required information governance issues around collecting data. It's pseudonymized, so we can't see the details of patients or identify the specific patients that you are providing care for in your unit. So it's been through many iterations. So for those of you who are entering data, many, many thanks. We know it is still a challenge to do that, but we've got more than 5,000 cases in the database now as of this month, and each single one of those cases has been entered by a member of staff in a unit in our region. So thank you for that. It is a huge undertaking, but I hope it highlights how important it is to the staff that are providing care for these women on the shop floor. It should be pretty user-friendly now because we've engaged with the staff who are actually entering the data, and it's pretty quick to put the data in once you once you have done it a few times. And there will be some stuff coming about automatic data transfer. We're not quite there yet, but there is a lot going on in that space. More about that later. Would you mind moving the slide on again? So if you want a bit more information about what we've been doing, this is a paper that the team has written from Yorkshire and Humber about implementation of enhanced maternal care, and the QR code there for you to see what we've done. And there's a bit in there about the initial findings from the database as well. Next slide, please. And then just a little bit on national developments. So we have established a maternal critical care group within the Intensive Care Society. That at the moment is mainly critical care focused from some of the documents they specifically wanted to support, but we have sought input from all of the relevant national groups that are in this space when we publish those documents. We're hoping to have a MDT group nationally that will help to oversee the ongoing MEaCC rollout nationally and also further documents that still need to come. So in terms of the things that have been published in the last couple of years that might be of interest to you, firstly, we've got the Intensive Care Society Enhanced Maternal Care Unit Guidance that was published in 2023. That is a kind of very much a kind of hands-on how to implement enhanced maternal care. And again, it aligns to the Yorkshire and Humber document that you all know. Upcoming, we've got an update to the Intensive Care Society guidance, and there is an update to the maternal critical care section that's in there, which again aligns to what we're doing in Yorkshire and Humber, but gives a little bit more detail about what care should be provided in critical care and also how that links in with the teams in maternity. Nursing and outreach are ahead of the game. They've published their maternal specialist competencies, so that's an update. They already had some in the last iteration. And then we've also got the outreach competencies which mirror those. In terms of training, there's some development of a course that will support ICU nursing and outreach competencies, more about that later. And then from a data perspective, there's a lot of interest in the MEaCC portal and how that could be used both to capture maternal medicine data, and within this region we work very closely with our team in maternal medicine and have created a maternal medicine portal with support of the network, and also how that might fit into any updates to the national MSDS data collection, because at the end of the day we want all of this data to be in one place and to be usable and immediately accessible for people so that they can use it to improve care. So I just wanted to say at this stage, thank you so much to Lizzie, Viv and to Brian, who have done amazing work supporting MEaCC. Absolutely wouldn't be here without them. And you'll see them at various stages during the day because they didn't get off without having to get on this stage. Next slide, please. And then just a big thank you to all the people who have been part of MEaCC so far. So Sarah, I've already mentioned, as an obstetrician in the region, has been a huge supporter of MEaCC from the outset. Claire and Hilary from the network, now both retired, but were right there pushing things forward. Anna and Em, who also work within the network, still working in NHS England, but in different areas, who were really instrumental in getting things off the ground. And also Audrey Quinn for all her work in this space and that innovative work to describe enhanced maternal care in the first place. Everyone in here who comes to the MEaCC meetings, we all do it for free, so thanks. And it just shows the passion related to that within the region to get this right. And then particularly all of our individual providers on the shop floor who are providing MEaCC and entering the data. We wouldn't be able to do any of this without you. So that's it from me. Thank you. We'll move on to the next presentation.